Okay. Thanks, Nikki. Thanks, Katie. First off, appreciate CPOC allowing me to present here. Super excited to talk to everyone today. I know that many of you have heard probably the rumblings of CalAIMS and the Enhanced Care Management Program. I guess before I dive into that a little bit, I want to introduce myself. So I'm Larry too. I lead enterprise partnerships here at Pair Team. I work very, very closely with several of our partners, including our Justice Involved. And so, similar to what Nikki was said, at any time, please, feel free to raise your hand or drop any questions into the chat. Definitely want to keep it conversational. So let me share my screen. Give me a second. And so, just by a quick poll, how familiar is everyone in the chat room in regards to CalAIMS? If there's any familiarity, anything at all, feel free to raise your hand. If not, I'll have a good understanding of what baseline of information I'm working with here. And Nikki, can you just give me a thumbs up if you guys can see my screen?
See your screen, thanks.
Okay. So yeah, I think first off, in terms of today, I have several things that I want to make sure as a goal today. One, I want everyone here on the call to understand the $10 billion that's available through CalAIMS, right? To understand really what the enhanced care management program is in terms of how it might be applicable to your county. And then lastly, ways that you guys can take advantage and send referrals on over. Okay. And so really the biggest opportunity for everyone on the call today is to leverage like the 10 billions in CalAIMS to provide vital resources for both youths and adults transitioning back into the community. One of the things I want to highlight is when it comes to, Pair Team, we are 100% state funded through CalAIMS and the managed care plans. So nothing that the county has to pay or the patient actually has to pay. So kind of kick things off in terms of Pair Team's mission. For us, at our core, our mission has always been to provide the highest quality of care to the most underserved and marginalized communities. We do this through the Enhanced Care Management Program, but we're a little bit different than the other ECM providers that you guys may be aware of. Typically, other ECM providers are typically your federally qualified health centers, your community health clinics. The only downside to that is most of the folks that are going to participate in these benefits have to physically come in. And what you guys see, and what you guys also probably understand is that when it comes to these populations of focus that are being targeted, right, you're homeless, severe mental illness, substance abuse, justice involved, you'll see that one, either they, can't come in, whether that's financial, transportation, personal, or two, they just don't want to. And so we leverage a lot of technology to be able for them to access all these benefits via telehealth, via their phone. And so here's a little snapshot of our leadership, just so you guys understand who exactly is steering the ship. Our CEO founder, Neil, is an engineer at heart, was previously at Forward Health, building out the digital primary care experience. Dr. Favini, he's our chief medical officer, was previously at CareMore and also several FQHCs and safety net hospitals. And then Dr. Ostrovsky, he's our senior advisor, was actually the chief medical officer for Medicaid during the Obama administration. And as well as you can see on the right, some other logos from the folks at Pair Team, whether that's Cerebral, Optum, Blue Shield California, but we definitely have a good amount of folks on board that are very talented. So right now, when it comes to the Enhanced Care Management Program, Pair Team is actually one of, if not the largest ECM provider now in California. Just as a reminder, the ECM program is targeting the sickest of the sick, right? Your justice involved, your at-risk youth, your frequent flyers to the ER. What we're seeing out of our 5,300 patients is that many of them haven't seen their doctor in over 3 years, right? And the reason why this is relevant is because when it comes to these populations, most of the times either, like I said, they can't come in or they don't want to. We make it very, very easy for them to participate in these benefits because we do everything via the phone, pop-ups at our CBO locations, and then also visiting them where they're at. Patients that are enrolled, the 5,300 are loving it. We're seeing almost a 58% reduction in emergency room visits, right? A 29% reduction in hospital stays, a 57% remission in depression symptoms, right? So very, very much, very significant health outcomes. And I honestly think, for folks on the call, the one of the biggest things that we provide in regards to support outside of clinical and mental health support really is that social support, right? Because if you take a look at the middle of the slide here, we have about 70 to 75 community-based organizations that were already formally contracted with us. That includes your homeless shelters, your food pantries, transitional housing, transportation services, what have you. So very much can help with housing issue you guys may have. For example, we're able to help with 288 and 290 offenders. So a lot of different ways that we can leverage not only our technology, but our network. And as a reminder, again, feel free to stop at any time in terms of dropping in any questions.
I had a
But right
quick
now,
question, Larry, if I could
yes.
just jump in real quick.
Mhm.
Based on the last slide, and I know you kind of touched on how Pair Team kind of links, yeah, thanks so much. How Pair Team like links individuals with community organizations. Um, I know in some jurisdictions, like CBOs and resources might be limited. Just curious to see if, this is kind of presented as a challenge or something that, your folks have flagged for certain areas where certain, there might not be as much resources. And then I know you also mentioned telehealth. So is that kind of kind of partake in that role of kind of delivering services?
Yeah, so to kind of answer your point, Nikki, obviously, we are a good option for folks that might be in certain care deserts, right? They don't have any resources nearby, maybe more rural. So we do leverage a lot of the telehealth services. So if you take a look, this is a slide that kind of highlights some of the benefits that we're able to drive to patients, right, by just using technology. So I'll give you an example. Right now, we're working with San Bernardino County, specifically post-release, right? And as you guys all know on the call, when they get released, they get about 30 days medication, a list of ECM providers, and that's pretty much it. Oftentimes if they skip medication, right, everything starts snowballing from there. So for us, if they're having an episode, we can enroll them, same day to be able to talk to one of our NP providers, right? Do a virtual urgent care assessment right there. If they need be, we can send a script to the local pharmacy, right, with any kind of medication management. So able to really leverage a lot of technology to be able to address some of these gaps. But good question.
Thank you.
Mhm. And so, yeah, this is the coverage that, Pair Team has as of today. We are live across 10 managed care plans and actually at 27 active counties with about 70% coverage right now across California. Working on the rest of, and everything else is pretty much in deep discussions, including like partnerships. I know that we've been working with SF health plans, so pretty much making our way up and down the coast. If no questions in regards to coverage, I'll go ahead and skip this. And so just a quick refresher, right? Everyone knows that CalAIM stands for California Advancing and Innovating Medi-Cal, 10-year program over 5 years that Governor Newsom introduced in 2022. If you take a look at the bottom left, the ECM program that I've been discussing really is focusing on the 5% of patients that typically account for half of the overall medical spend, right? So like I mentioned, these at-risk populations now have very, very comprehensive wraparound care to keep them out of the ED, right? And just for more context, I don't know if everyone on the call knows, but for every time somebody actually goes into the emergency room, right, instead of actually calling one of these case managers, that's $25,000 to the taxpayer, right? And so very, very much CalAIM's a system, especially the ECM program, where everyone's winning. Patients are getting additional benefits. The hospitals are clearing up their emergency rooms to help those that are truly sick. And then the taxpayer saving as well, the state saving money as well. And so here's a list of the populations of focus that are eligible for this program, right? And I just as a reminder, the only requirement for them to be eligible for this program is that they need to fall under one of these populations, and they need to have a managed Medi-Cal plan. So going back to the previous slide, with Molina, HealthNet, LA Care, what have you, they would have to have one of those plans as well. But just from taking a look at this list, right, by enrolling folks into ECM, you're also going to not only you're going to be giving benefits to folks that are eligible, but you're also going to be keeping a lot of your officers safer, right? You can use ECM and specifically Pair Team as a way to enroll your higher acuity, patients, maybe those that have more severe mental health issues, because we do, provide a lot of that wraparound hand holding. And so taking a look at this slide, this basically shows where ECM falls in regards to, the CalAIM initiatives. So everything that you see on the left side of the screen is pretty much everything that's going on right now inside of, the prisons and the jails. Everything on the right that you see, whether that's PAC, DAPO, probation, DRC, that's on the far right. ECM falls directly in the middle, right? With the general logic being that now that the state is giving folks benefits 90 days pre-release, that we can hopefully enroll them into an ECM program so that day one, when they actually are heading back into the community, they know, who's their lead care manager, where they should go in regards to housing, all right, where to tap into. So yeah, this is a good illustration for that. And so really, ECM core services are not that different from the services provided by pre-release care managers right now, right? And so I think the biggest opportunity for those on the call is ways that your probation, your county probation can leverage Pair Team. And I'll show you in a little bit. It's very, very easy for folks to send referrals over to us. And as soon as we get that referral, we typically outreach within 24 hours. I'm sorry, let me rewind. We guarantee that we outreach within 24 hours. It's typically outreach within the first hour or two. And here's just a slide that kind of shows the purpose of this care management for the JI populations. I think it's no surprise here, right? Recidivism stays very, very constant around 44 to 50%. There's a huge need, right, for high-level case management because of a lot of these issues that are happening post-release. And so, this slide kind of talks a little bit about even though ECM is free, even though it's highly beneficial, right? You have access to clinical care, mental health care, social supports care. But when we take a look at the enrollment data, it's been flat across the board. And I think the general logic goes, all those that were motivated to take advantage of these benefits came into their local community health clinic and enrolled. But the truth of the matter is, these populations of focus, it's very, very hard to engage with them because they normally don't engage with the healthcare system themselves, right? So if you take a look at the right, across most of the managed care plans, they're averaging less than 1% enrollment across the board. With ECM being eligible for 5 to 6% of the populations, that basically signals that 80 to 85% of the population that are eligible for these benefits are not taking advantage. And I think the reasons why is because similar to what I said, most of the other ECM providers that you guys may have heard of are typically your federally qualified health centers, medical groups, community health clinics. Like I said, when it comes to these populations, they either can't come in, right? Transportation, personal, what have you, or when they do come in, they feel stigmatized, right? The staff treats them a little bit differently. They get rushed in and out. With virtual telehealth, those barriers get removed, right? I myself personally, I work in healthcare, but I hate making an appointment, driving down to the doctor, right? Sitting in the lobby. It's just, to me, it's a waste of time. And so this, with Parity, we make it as easy as possible for folks that traditionally wouldn't engage in these benefits to engage. And so this is just the slide that kind of highlights what I was talking about before, right? Just some additional stats here. The number one cause of death post-release is drug overdose, right? Mental health issues have been up on the rise post-COVID, so it speaks to the need for very, very high-level case management, to be very, very plugged in terms of not only their clinical, but also their behavioral. And so going back to this slide, like I mentioned, I talked a little bit about the benefits on the bottom half of the slide. I want to reiterate on the top half of the slide that one of the things that Parateam prides ourselves on is being 100% turnkey, meaning that as soon as we get a referral from one of our partners, we own all outreach. If the patient is eligible, after we check eligibility, we enroll them. And then from there, we provide all the services. So I'll give you an example. Um, you know, patient comes in, we get the lead, we guarantee outreach within 24 hours. After we're able to get in contact with the patient and the patient qualifies, we enroll them. As soon as they're enrolled, the first thing that happens is that we assign them and pair them up with their own dedicated lead care manager. Now, these lead care managers, um, depending on the counties that they're in, they're all going to be from the county. All of them are bilingual, and many of them have lived similar lived experiences, right? So able to quickly build that trust and rapport that's so vital continuing these relationships. So if you take a look at this slide on the left, top left, you'll see this is one of the case studies that we had coming from San Bernardino. 42 years old, in and out of homelessness at this time, uncontrolled diabetes and anxiety, and was using. Within 9 months, was able to find stable housing using our CBO partners, and also stable employment using our CBO partners as well. Avoided any emergency room visits compared to the year previous. Started stabilizing her diabetic and depression symptoms, and really just started sobering up and repairing her relationships. So as you guys can imagine, very, very life changing for folks that need a little bit of support during this tough time. And Nikki, just to check, are there any questions in the chat?
I am not seeing any. Just a reminder for folks, if you have a question, feel free to use the chat or raise your hand. Thanks.
Mhm. And so I always tell people to see Pair Team as really three buckets. I touched a little bit on the CBO network on the left, which is our 75 CBO partners that make up our, homeless shelters, food pantries that provide a lot of those social supports. Um, Currently, we are not live in Solano County, but we are currently working on it. Yeah, so honestly, we are in deep discussions with the counties, the other uh, 31 counties that we're not live in. So I think it might make sense to start those discussions now, because obviously when it comes to contracting with the county or sending referral or it takes some time. But for those folks on the call that are live with the counties that we're live in, you can send them referrals on now. And so going back to this slide, that CBO network is what I was quickly talking about. In the middle, you'll see our medical group. Now that is made up of our team of MDs, NPs, RNs, licensed clinical social workers, community health workers, therapists. They provide a lot of that support virtually, right? So via telehealth, we started doing, we do pop-ups at our CBO partner sites, and then we started visiting the patients where they're at using our mobile van service. And then lastly, we have our own tech platform that we've created ourselves. And this is what our CBO partners use as well. And so, I think the biggest opportunity here is just another resource for folks, right? To provide additional resources to folks in the community. Now, this is typically the structure that we have with some of our JI partnerships. But I think the biggest lowest hanging fruit here really is learning how to send a referral on over. But I guess before I do that, kind of wanted to talk quickly about some of the work that we're doing in San Bernardino County. So right now, we are in a partnership with MAP. For those that aren't aware, MAP stands for Multidimensional Anti-Recidivism Partnership. It's a mouthful. It's basically San Bernardino County's way of separating reentry with law enforcement. And so they've been sending folks on over to us, as well as folks from the DRCs in the Inland Empire. And then lastly, also in deep discussions with San Bernardino CSRI, but the partnership is very, very straightforward. Basically, they engage with folks, reentry services that need additional healthcare support, whether that's clinical or behavioral health. So we work with them specifically to not only provide that support, but also housing support in case they have issues placing folks. And so a lot of different entities that we've been engaging with, because I've been hearing through the grapevines that their leadership is telling them to find out ways to leverage additional state funding, right? And so through the $10 billion available through CalAIMs, there's still a lot of resources up for grabs. So in regards to sending a referral over, it's very, very straightforward. For those on the call, if you're able to, if you actually search up ECMreferral.com on your web browser, you'll actually go to our external, this is basically our external referral source. So anytime one of our partners wants to submit a referral through this link, like I mentioned, once we get that link, our community engagement specialists outreach typically within the hour, but guarantee within the day. We also have a hotline that you're able to leverage. Now, this is not a live hotline for folks, but if you're able to leave the information of the patient that you are interested in referring over, we can definitely outreach to them as well. And then lastly, I have a referral form that we've been using with several folks within the Inland Empire that we've seen success with. Us ourselves, we always pride ourselves on being a tech company, so we try to steer away from that. But we also know that everyone has different processes. But really, ECMreferral.com is very, very straightforward. It takes about 2 to 3 minutes to fill out a referral. It's very, very basic information such as what's the patient's name, what's their date of birth, what's the best point of contact, what population focus do they fall under. And just to kind of reiterate for everyone on the call, those transitioning from incarceration are identified and defined as those that have been incarcerated within 1 year, right? So they would be eligible for these benefits. I'm sorry, do we have any questions? Let me double check that.
It was a question about the
Oh,
link, but it's on the slide. And
perfect.
as a reminder, we'll send this out afterwards, so folks have it.
Yes. But yeah, it's very, very straightforward. Once we get that information, we're able to outreach the patient. And like I mentioned before, once we do get that, that's pretty much all that needs to be done from the other entity's standpoint. And so outside of that, outside of having that, we also have branded collateral that to bridge the gap between, your staff and then how to explain this to the patient. Um, so we have flyers, posters, right, business cards, things of that nature to send out. Um, but I would also say that one of the things that we've had a lot of success with, and it's also depending for those on the call, depending on the amount of volume you guys have, is like a warm transfer line, right? We have it with some of our hospital partners where, you know, let's just say an agent is talking to an individual who is eligible. They know that they have managed Medi-Cal. They fall into the populations of focus. We can definitely create a dedicated line for them to call into to be able to get a live person and to warm handoff over the phone. Here's just a few testimonials of some of the stories that we hear. For us, it's like I mentioned before, it's always I always tell my team anytime they're having a long day to just to be able to pull up these because very much life-changing for a lot of folks that just need a little helping hand. But I'll like I mentioned, I'll share this in the slide that everyone can have it as well. So we don't want to take up too much of the time for everyone on the call. But that's pretty much it for the slide presentation. Would love to hear if anybody has any questions at this time or anything they want to add.
There's a question in the chat. I can read it out loud for you, Larry. Are local ECM providers subcontract by you at Pear Team?
So the other ECM providers are not subcontracted by us, but what we do is we allow folks, especially nonprofits, to participate with ECM funds by sending referrals on over. But no, we don't have any ECM providers under us. Are services provided in Santa Clara? As of now, we have the paperwork submitted for Santa Clara, but it is currently not live. But we are expecting very, very early in Q1.
Did you mention how many counties in California Pear Team is currently working with? Forgive me if you mentioned this earlier on, and I'm just...
We are live in 10 managed care plans across 27 active counties.
Got it. Thanks so much.
So if anybody is on the call that's listed in any of these counties here, would love to start that conversation now because we're already live here. For any of the other counties, we could definitely have conversations because we're in the process right now.
And then I see a couple more questions come through. One on can you go over the timelines for when you can start using services if still in custody and after release?
Yeah, so technically, 90 days pre-release, they are able to enroll in Medi-Cal. From that time that they are enrolled into Medi-Cal, and from the time that they get enrolled into a managed Medi-Cal plan, the second that they get enrolled into a managed Medi-Cal plan, they can now participate in ECM. Um, and so we're working with folks, and it's actually interesting because we have a CBO that we work with that actually has access inside the prisons. And so we're looking to have him help enroll folks into managed Medi-Cal because we see that that is a very, very big problem that many folks are running into. Um, but yeah, would love to talk to folks and maybe find out a solution there on the call. And there, so that is yes and no. So there is an in-person requirement. We give all our patients the option to do in-person, but this is all based off of patient preference, Razine, and they all prefer to actually do telehealth. But we also do pop-ups at our CBO locations as well as visiting them now where they are through our van service.
Thank you, Larry.
Mhm.
Any other, if there are any other questions, please feel free to put them in the chat or also come off mute or raise your hand if you'd like to ask that live as well. I had a question about the whole referral process. From it's just my understanding from DHCS, there was a whole ECM policy guide and certain standards that need to occur when referring an individual to ECM. So just want to kind of ask if, you know, what kind of the engagement has kind of looked like with the department to just make sure that everything's all in align with like certain expectations from the state.
Totally, totally. And this is something that work with several departments, and this is actually the issue when it comes to working with the county, right? Because it's very, very slow to get that county contract. But right now, what we're also hearing from folks on the front line is like, hey, we need additional resources, right? We need additional help with housing and things like that. And so externally, folks can go to our website and submit a referral throughout any process. But I think once we notice a certain amount of traffic, we do want to make sure that we get like a formal process put in place.
Great, thanks.
Mhm. Mhm. And so, I know if there's no additional questions, I want to thank, Nikki, Katie again for your guys to organize this. Appreciate CPOC, appreciate everyone's time on the call. Would love to have a conversation with anybody on the call that, is interested. And then also at the same time, any conversation with folks that maybe we're not live in yet, to maybe get a head start. Yes. And so, folks, Nikki and Katie are gonna be sharing my information via email, but I'm also putting in my email in the chat as well.
Cool. Thanks, Larry.
Mhm.
Um, I just had if there are just to follow up on folks, we will be sending out the slides and all the contact information for Larry and at Peer Team after the presentation. We appreciate it. I do have another follow-up question. If we can go back to a previous slide, Larry, on I think it was like the 10th slide. It was kind of about ensuring, yeah, ensuring the warm handoff, what that kind of looks like. Obviously, 90 days prior to release, folks are, receiving services, and post-release, we kind of want to ensure that the services still occur and there's a warm handoff there. I know you're already working with some probation departments. Maybe you can speak to what that kind of looks like in more detail of the kind of warm handoff here.
I mean, I will be honest, I feel like everyone's a little behind schedule in regards to having this polished. So most of the instances that we're working with probation and parole is mainly through like DRC and the PAC and DAPL meetings. But very much we're talking very frequently to the managed care plans because they're being very, very selective about who they designate as a justice involved ECM provider inside the institutions. So I think to TBD, Nikki, I think everyone's still trying to figure that out.
Yeah, definitely. That's helpful. Well, we'll pause for a beat here if there are any final questions that folks have. again, this will be sent out, the slides and Larry's contact information, so folks can reach out. Any other?
I think I'll just end with one last thing. It's just that, there's $10 billion in resources, right? I would just encourage you guys to take advantage. It's very, very easy for us to work with you guys, so don't hesitate to reach out.
I see a hand. Natasha?
I did have a quick question. I know that sometimes with these systems, there's a lot of partnerships, but what about the frontier communities who don't have a lot of humans working? How do you guys typically service them? Is it just a lot of?
Sorry, when you say the frontier communities, do you mean more of the rural?
Yes, because we're smaller than rural.
Gotcha. Gotcha. So I will admit, one of the challenges when it comes to, frontier or rural is really building out that CBO network. So that's a challenge that I feel like regardless if you're a para team or another entity, you're gonna run into that building out in regards to those areas. But I think leveraging a lot of that telehealth, right? A lot of the remote services, whether that's Meals on Wheels, Lyft and Uber, we could still find ways that we can, fill in those gaps.
Because we don't even have Lyft or Uber in our community. So it's a big challenge because we have partnership who already tries to provide transportation and it doesn't work.
Gotcha. You guys are too spread out.
Yes. Big
Gotcha.
geographically, but small in people.
Totally. And so yeah, in those instances, I think we'll still be running into the same problems that many of the other folks are running into. But I think outside of that, it's I think one of the biggest competitive advantages we have is really that longitudinal care, right? So like I'll give you an example. We work also with the hospitals. They see a lot of these populations that come in very, very frequently for readmissions, right? But what they don't have is the capacity to follow these patients around. And that's what we were able to do in regards to pairing up with their own dedicated lead care manager, right? Very high frequent checkpoints to keep them out of have the hospital engaged. Does that answer your question?
It does. It's like adult wraparound, kind of.
Any other questions before we wrap up here? All right. Well,
See you guys again.
Yes. Thank you so much, peer team. Larry.